thanks a lot, and thanks for showing up late Tuesday night after a long day. I'm Tyra Krause, as you know, and I am I'm heading the epidemiological infectious disease preparedness at Statens Serum Institute. And this is the building where we are working. So if you come by to Copenhagen, come by at my office to say hello, or to say hello to Sten, who's sitting just on the floor under me. So our institute is quite old, more than 120 years, so we have quite some experience in prevention and control of infectious diseases. We also do research, counseling. We have worked with vaccine development and supply for a decade, and we also host the national reference laboratories for infectious diseases. And the last 20 years we have done quite an effort to build up the digital data infrastructure, and we also have a national biobank with biological samples from 3 million Danes, so that we can also do research. For the Danes, you know, there are some issues quite now about informed consent if you want to use these samples, that we are struggling a bit with. And now I have to apologize for those who have attended the course, because there will be a very few slides that you have seen before. But our institute, or our department, works with public health surveillance, and that's the ongoing systematic collection, analysis, interpretation, and dissemination of health data used for public health prevention and practice. So we collect data, but it's data that should be used for some kind of action. So we collect notifications from that physicians for a lot of infectious diseases. They have to make mandatory notifications to us. We also collect laboratory data on laboratory test results from the microbiology labs in Denmark, and we link them to different healthcare databases to supplement with additional information. Then we analyze and interpret the data, but we also have to do real-time research to support the guidance that we have to give. We report the data on our websites, in newsletters, and also in research papers. And then we give the advice to our National Health Authority or the Ministry of Health. And this is an example of one of the last press meetings we had in Denmark. That was in the end of January 22, where I had to present the risk assessment of the Omicron variant that actually led the decision to lift all restrictions in Denmark already by the 1st of February 2020 as the first country, I think, in Europe. When you make when the decision managers decide on some kind of response, of course we have to follow what is the effect of this response, and then you are back into this surveillance loop. So the COVID-19 pandemic has been a really long journey for us. There have been a lot of different game changers on the way that we didn't predict to begin with. And we have had to work extremely hard to set up new surveillance systems and to build up a test capacity, because we did all the community COVID-19 testing in Denmark and all the whole genomic sequencing. And we also had to continuously try to address some of the many research gaps that evolved throughout this 2.5-year journey. So how did it turn out? I think actually in Denmark it went quite well. In this slide you can see the cumulative excess mortality per million people, and it's data from our world of data. And you can see the development in different countries, and you can see that Denmark is quite low here together with some of the other Nordic countries. And also in terms of the economy, it went quite well, at least according to this paper that came out in The Economist the 1st of January 2022, which showed that where they tried to assess different countries along 5 different economical measures, and they also found that some of the Nordic countries were in the top in terms of having okay economic results. So what are the reasons for this? I think there were several reasons. First of all, there was a strong political commitment to tackling this pandemic. They put a lot of funding into dealing with it. There was quite a good cross-sector collaboration, both at the ministerial level, but also at the agency level. We had this strong digital data infrastructure in place already before the pandemic hit. We achieved to build up a very high PCR test capacity and also whole genomic sequencing capacity. Maybe we did test a little too much in some periods, but at least that meant that we had a very detailed picture of what was going on epidemiologically. I could also assess all the new characteristics of the new variants that occurred. We had an efficient vaccination rollout. We achieved one of the highest vaccination coverages in Europe. And of course, that was because there also was a very high degree of public trust in the population, in the authorities. So they actually followed the recommendation coming out from the public health authorities. So, and that is, of course, very important. And that also meant that we didn't have so many mandatory measures in place. Of course, we had restrictions, but we never had mandatory vaccination, for instance. We used a vaccination passport, or had a corona passport, we called it, but you could also get that if you had a negative test. Of course, COVID-19 has had an immense impact on health globally, and this is the most recent data from the Global Burden of Disease study that came out in May this year. And you can see that for 2021, COVID-19 was the second leading cause of mortality globally. And you could also see at number 5, we had other pandemic-related mortality, which is likely due to lack of access to health services or maybe disrupted vaccination programs during this period. But it's strange because I think you all feel the same. It seems a very long time ago now. But this was a test center that I used to visit quite a lot. But it was not closed until last year in March. And here, this is my family. I visited my son last New Year, or not this year, but last year in 2023. And he was staying in Hong Kong and studying. And we were allowed to visit him, but we had to go through this immense testing scheme before and after we entered. And actually, we looked quite nice there, but we are hardcore criminals because we had to wear a face mask even when we were going outside. But we dared to take them off here just while taking this photo. And I think you also remember 2 years ago, we had one student isolated in one of the rooms, and we could just wave to him while we had the party down in the garden. But it was in March 2023 that there was this announcement from WHO saying that COVID-19 is now an established and ongoing health issue which no longer constitutes a public health emergency of international concern. That's almost like saying that the pandemic is over, because there's been some discussion whether WHO could say that, but this is what it actually means. This announcement also came with some recommendations, and I'll list some of these recommendations here, that countries needed to sustain the national capacity gains and prepare for future events, and we should avoid the panic neglect circle. I love this expression, but it's that something happens and you're all in panic and you do a lot of investments, and as soon as it's over, you kind of forget about it and you make cut downs. And this has happened in many countries, and I know many of our neighboring public health institutes, they've had to go back to the level they had before the pandemic. So, and in Finland, they're now firing 30% of their staff. So that is actually happening. Then we had to kind of normalize COVID-19 vaccination. It should be we had to integrate it to the life course vaccination program. I mean, most countries also have special facilities where the vaccines were provided, but we had to integrate it kind of in the infrastructure that we had before. And we also had to integrate COVID-19 in the existing respiratory pathogen surveillance, including diverse data sources, and they were more specific in this recommendation. I'll come back to this. We had to prepare for long-term availability and supply of medical countermeasures, and continue to support research. So that were the recommendations from WHO. And in this talk, I'll focus on 3 pillars: what we have done to strengthen surveillance, what we have done to strengthen research, and what we have done to strengthen preparedness. And here I'll focus on One Health preparedness, because that's really important now, that you kind of work together across different sectors, particularly with respect to the zoonotic threats. And you have to do this in international collaboration, because of course the pathogens, they don't respect the borders. So here we have the surveillance pyramid, and this is something we are very interested in as infectious disease epidemiologists. You'll have a population at risk. Some of them will get asymptomatically infected, some will get symptomatic, some will attend a medical doctor, some will get hospitalized, and some will die. And so far, most of our surveillance systems, they have included the top of the pyramid. And actually, we got very aware of this after the swine flu pandemic in 2009. Because at that time, many countries didn't have a surveillance system in place to capture cases hospitalized with influenza or dying from influenza. So we've been working on that to establish mortality monitoring systems, and also systems surveillance of severe acute respiratory infections. But what we realized during the pandemic was that we actually also need to know something about the base of this pyramid. And we do need that for early detection of transmission of new pathogens, and also in order to assess severity, because if you only have the top of the iceberg and you don't know anything about what's circulating in the community, then you cannot compare one variant to the other. And you also need to have some kind of assessment of immunity if you want to do mathematical modeling. So this is something we have worked on. So in terms of strengthening the surveillance systems, we have implemented wastewater surveillance. I'll come back to that. We have implemented survey-based syndromic surveillance for influenza-like illness. So we have we also had that before the pandemic, but we have a group of voluntary people who report weekly whether they have respiratory symptoms, and we use that as a syndromic surveillance system. Then we have the all year round now GP sentinel surveillance for respiratory pathogens, and a sentinel surveillance system, GP sentinel surveillance system includes GP clinics that volunteer to report on a weekly basis the number of patients they see in their clinic and the number of patients that have respiratory symptoms, and then they send in swabs from a selection of the patients, so that we also have a virology surveillance in place. And this has been expanded to run now all year round. Previously, it was only in the winter time, and of course that's because we have COVID-19 circulating all year round, but also because we know we had this situation with H5N1 that we see in wild birds, but now also in cows in US, and where there's a concern whether we could see transmission into humans, and we would not be able to detect that unless we had some surveillance system in place running all year round. We have increased our capacity for whole genomic sequencing, and then we've also worked to scale up our ability or our flexibility in terms of scaling up test activity. So we have used this system where of self-sampling, where now we have some voluntary, we have it implemented in some workplaces where they can voluntarily swab themselves if they get respiratory symptoms, report the symptoms, register the sample in an app, report the symptoms in the app, and then send it to us. And this system we consider that a preparedness testing system that we would also be able to use in a new outbreak, and also in case we had to start community testing again, then instead of setting up tents with personnel in the tents, we could use this system. So, wastewater surveillance. The concept is that people shed viruses for some pathogens in the feces, that we can take samples from the wastewater plants. These samples can be analyzed with PCR, and we can also look into do whole genomic sequencing. There's a lot of data processing that has to be done because you have to adjust to how much rainfall there has been, and also adjust for some or standardize for some fecal indicators in the sample. So there's quite a lot of analytical work, but then you can actually measure the concentration of follow the concentration of SARS-CoV-2 in these samples and share the data with the health authorities. This system has quite a high sensitivity, independent of clinical testing in the healthcare system. It's cost effective to survey transmission in communities. It also has the potential for One Health surveillance, because you would be able to use it in slaughterhouses or maybe in pig farms. And it's also, so in that sense, it is really a promising supplement to the existing surveillance systems we have. So this is the results for the last week, where we can see that there's an increase in the concentration of SARS-CoV-2 in the wastewater. So we seem to maybe go into a small summer wave, but we don't expect this to be something that will result in a high number of severe cases at this stage. It has also been used to monitor mpox. So this is an example from United States in California, where they monitored mpox in different areas in wastewater. And here are the red, the ones, the weeks or days where they had positive samples. And they had looked into how well it correlated with the reported cases. And what they found is that the mpox DNA, it was detected before or within a day after the first cases were detected. And there was a very good correlation between the mpox concentration in wastewater and the incidence of mpox cases. So what they conclude is that there is really a promise for future use of this method, and you could use it as an adjunct to the public health tool. So there's a lot of international awareness on the potential use of wastewater surveillance now. So the HERA, which is the new Health Emergency Preparedness and Response Authority under the European Commission, they have gone together with the Gates Foundation to fund this Glovicon network, which is the global consortium for wastewater and environmental surveillance for public health. And you can see Sten is here because he's leading another initiative, also funded by HERA, to build up a network that is aimed at building up capacity for wastewater surveillance in the EU. And you can see here at the launch of the meeting, and what we have heard is there's also interest in funding from Wellcome Trust and likely also the Novo Nordisk Foundation in this, because they see it as a tool for signal detection that could be used globally. And one of the advantages is that it's easier to share data across countries from wastewater surveillance because we don't have the same challenges with the GDPR that we have from the indicator-based surveillance. So this is just to show our GP Sentinel surveillance. We also see an increase in the proportion of SARS-CoV-2 now in the most recent weeks here. We continue to do whole genomic sequencing, and of course now we use it to track the SARS-CoV-2 variants, but I mean it's also so that we have this infrastructure in place so we can use it when a new epidemic hits. What we can see now is there are some new variants that comes from the JN1 variant that occurs KP3, and there's a KP2, and we see a small increase here. We don't expect them to be more severe or transmissible. We just think this is a matter of the waning immunity since it's some time since we had have been maybe vaccinated or since we had the last wave. So now I'll talk a bit about surveillance and research. And in Denmark, we have this digital infrastructure, and the core in this system is the microbiology database, where we collect all test results, microbiology test results, and can in that way we can identify patients with COVID-19 or any other pathogen. We have the data from the whole genomic sequencing. We can link with the National Patient Register to look at severity and also whether they have underlying illnesses, whether they've been previously hospitalized. We have the civil registration system that means that we can explore transmission within households because we can identify people in households. We have also data on occupation and workplace. We can link to identify whether people are living in nursing homes, and also we can link the people at nursing homes with the staff that are connected to the nursing home. And we have a vaccination register comprising all given vaccines in Denmark. It's mandatory to report all vaccines in this register. Which means that we can do quite a lot of nice EPI research just using the data we have from the electronic registers. So we can do the EPI work like following trends, identify risk groups, assess severity. We can do vaccine effectiveness and safety study. We can detect new virus variants and also assess their transmissibility, severity, and immune evasiveness. But there's also been some research gaps, things that we could not really have difficulties in addressing. And I've tried here to list up some different public health research domains. And I've tried to divide them into two groups. One about the things we need to know about in order to do a proper risk assessment. And then also some of what we need to know about in order to do good risk management, because I mean we also give advice to the decision makers who are responsible for the risk management. And you can see this is some of the work that I also mentioned before that I think we've been quite good at. We have not been good at studying really transmission dynamics. So whether you so exactly what is the source of transmission has been difficult to study. We have not been good at exploring all the whole genomic sequencing data we have. We have identified variants and done studies of those, but really using the phylogenetic data to find out and link it with register data to find out where transmission actually occurred. Was it in schools? Was it in workplaces? Or was it in special events? We haven't had the capacity to do that. And then when it comes to risk management, there's a lot of the non-medical countermeasures that we don't really have evidence for. And that's one of the things I think would be really interesting if we could be better at this for the next pandemic. And we could have done maybe more intervention studies. Of course, it's very difficult when you're in the middle of a pandemic, but I think in the later phases of the pandemic, we could have done it. If we had had protocols for intervention studies in place. There were some intervention studies done on face masks, and there was this meta-analysis published. That was in 2002, where you actually could see there was a moderate effect on community transmission as using face masks as source control in these intervention or these RCTs. But we could also have done it, I think, on some of the other countermeasures, like the contact tracing schemes, and maybe also some of the testing schemes that we used. We recommended bi-weekly testing of school children. I mean, you could have done that in a cluster randomized design, but then you need to have some kind of contract with the politicians that it's okay and with the population that it's okay. And we didn't have that. We actually tried to do it. I also think another good example is around the vaccine boosters. Some countries, they give vaccine boosters now in the spring to the most susceptible population or the most vulnerable populations. We don't do it. Actually, we are not certain what would the effect be. I think that would be a wonderful place where you could actually do a nice intervention study to explore what the effect really is. So I think this is something we need to find a way to do more of. Another thing is that we would like to work for is to establish some research collaborations with academia that we establish in peacetime, so that we have data sharing agreements in place, and we have the relations to the different research groups, so that we during a crisis actually can include academia much more in our response. We did have some research collaborations with the Danish blood donor study, so that we could follow the seroprevalence. We have established research collaborations with some really good people in network analysis and phylogenetic analysis that we could kind of reactivate in case of a new crisis, and also on mathematical modeling. And I think in UK HSA, I think they have something similar with some research networks that they get funding for and that are established, and I think that's a very good way, so we really could use all the capacity and the expertise that is in academia. We also need to join forces in the international research networks. There was one very good example. We participated in this vaccine network with the other Scandinavian countries, where we could do register-based studies on vaccine effectiveness and safety. And that's, of course, important when you have some very rare events. This is an example of a nice study that explored the association between SARS-CoV-2 vaccination and myocarditis. And they could see that there was a signal with an increased risk in the younger male population, particularly associated with the Moderna vaccine. And of course, this is very important information. I have to say the risk was lower than what you would expect from getting infected. So that was quite important also to know. But a good example of a nice international research network. Now there's also this new player, I mentioned it before, the Health Emergency Preparedness and Response Authority underneath the European Commission. They have the responsibility now of procurement and stockpiling of medical countermeasures in EU. So they address all market challenges and all the supply chains to kind of ensure that we will not be in the same position as we was last year, where suddenly we didn't have access to plasticware because for the testing equipment because China had been locked down, or we didn't have enough personal protective equipment. And they also look into the vaccine supply chains. They also work on threat assessment and intelligence gathering. So they're making a huge data platform where we will upload all the wastewater surveillance data, and they will also collect data from ECDC. And then they also work for research and development of epidemic countermeasures. So I think the plan is that they will also support some clinical trial networks that they can be kept warm between epidemics, and then they can be activated in the epidemic, so you can quickly do randomized controlled trials of new medical countermeasures. And I think they are also opening up for that you could do the same if you had ways of doing trials or intervention studies on social countermeasures. So that would be quite interesting. This is a laboratory network that we are participating in that is also funded by HERA, and the idea is to kind of complement all the expertise in the laboratory field across Europe, so that we don't do the same studies, all of us, but we aim at sharing pathogens, and then we can do genotypic and phenotypic characterization of the pathogens, and also include people who have expertise in animal studies and transmission models and models of how to assess pathogenicity, so that we kind of try to coordinate the efforts so that we can provide a better risk assessment. Okay. The final part is going to be on One Health preparedness. And One Health, I'll read up the definition to you, is defined from the One Health high-level expert panel as an integrated, unifying approach that aims to sustain sustainable balance and optimize the health of people, animals, and ecosystems. It recognizes that the health of humans, domestic and wild animals, plants, and the wider environment, including ecosystems, are closely linked and interdependent. And it speaks into interdisciplinarity and transdisciplinarity. So I think a lot of the challenges that we are facing now are One Health challenges like climate change, loss of biodiversity, AMR, all the zoonotic threats, and we really need to work across sectors in order to tackle those. A good example is the situation now with the avian, high pathogenic avian influenza H5N1 that has been spreading in wild birds the most recent years. We have seen increased detection in mammals, in foxes, cats, sea lions, seals, mink farms, outbreaks in Spain and in Finland. And now we also see this outbreak in the US in cows. So what do we know now? Well, we know it has likely been introduced by wild birds into a cow, and there's likely just been one introduction. There's likely transmission between cows. The exact route is not known, but we know that they have mammary gland infections, mastitis. So it's likely with the milking equipment and then also between farms when they transfer cattle. We know that there have also been poultry farms affected when you have poultry and cattle farms together, and it's likely from the cows to the poultry, but you don't know exactly how it has happened. We know that cats have also been infected on these farms, likely because they drink raw milk. And then we know we have seen 3 human cases. Fortunately, they have only had mild disease. 2 had only conjunctivitis. 1 had a respiratory infection, but it was mild. And luckily, we have not seen any transmission from human to human. We are concerned about this because will this virus, when it starts to transmit in mammals, will it adapt better to humans? And could we face a pathogen that could transmit to humans and also between humans? And also, the more humans can be exposed via animals, the higher is the risk of recombination with a seasonal virus that could result in a completely new virus that could cause a pandemic. So that is the concern. In the US, a lot of different agencies, they have to work together. So the CDC and the FDA and the USDA, and they all have different responsibilities. So CDC assesses the human risks. The FDA is responsible of the safety of the milk and meat products, and USDA is they're responsible for assessing and mitigating the risk in the livestock. And this is very challenging, and we've heard that there's a lot of discussion that the USDA have not been transparent enough, they have not shared the data, they have shared the viral data too late and the sequencing data. So One Health collaboration is really difficult, but it's necessary when we have zoonotic threats like this. So ideally, we would have some integrated surveillance systems where we could do whole genomic sequencing of pathogens detected in humans, whole genomic sequencing in pathogens detected in in animals, metagenomic sequencing of different environmental samples like slaughterhouse waste or wastewater, and also metagenomics in pools of mosquitoes and other vectors, and also in wild birds. In that way, we could kind of combine, and if data were also shared between environment, the animal, and the human sector, then we would have a really strong surveillance system. We have aimed at working with a One Health approach in Denmark. We did that during the mink outbreak because our institute was responsible for analyzing the samples from both the veterinary side and also from the humans. And what we could see there was that we had a really intense mink farm industry in Denmark, 1,200 farms. And in those areas where there were mink farms, you can see here the proportion of infected mink farms were up to here 60%. And it is likely also underestimated because I think some of the farms went under the radar. And if we look at the proportion of human cases who had a relation to a mink production that were infected, it was up to 50% in those areas where they were densely populated with mink. So these people, mink workers, they had a higher risk of being infected than people working in the healthcare sector or in any other occupation. Using the genomic sequencing data, we could describe the transmission patterns. So this is one of the first farms that were infected. We could see that there was an index worker who had SARS-CoV-2, and he had the index variant, the Wuhan variant, without this mutation. In the mink farm, there was some adaptation occurring, and they had all this mutation, and that actually formed a whole new viral variant, V1298. And we can see that that a woman, the wife to the man who owned the farm, was infected from the mink with this variant. She also worked at a nursing home, and she infected a lot of people at the nursing home where they had a huge outbreak. So there was also some deaths there. So that was, in this way, we could document that there was human to mink to human transmission. And it was decided to cull all mink based on the occupational risk, because we saw this intense spillover, and also because of some concerning variants occurring. This is a paper for Vanity Fair where they interviewed a mink farmer, and he says, now I'm not a mink breeder, I'm only a mink killer. I think that was quite funny because, I mean, the mink breeders, yes, they're mink breeders, but they kill the mink every year. So I think they have always been mink killer. But of course, it was terrible that this occupation was closed down completely. Fortunately, there is One Health collaboration going on. There's this cross-agency One Health task force in Europe. And that's important because a lot of the challenges we are facing, also with infectious diseases, really need a One Health approach. But we still have a lot of challenges: weak health systems, climate change, mistrust, social inequality, ecosystem disruption, migration due to war and crisis. But to be a little positive here in the end, I think we can conclude that the infectious disease preparedness has been strengthened post-COVID-19 internationally. We have stronger surveillance networks, better frameworks for research. We have a whole institution that works with supply and research in medical countermeasures, and increased awareness on One Health preparedness. So that will be my final conclusion. Thanks.